The only way that we can scientifically know what the sex of the baby is through IVF and pre-implantation genetic testing looking at the XY. As we say in Arabic, أطفال الانابيب وفحص الكروموسومات الجنسية قبل إرجاع الأجنة. What the embryologists do is they make a small hole at the wall of the embryo. It does not affect the embryo. No harm happens to the embryo with taking this. And then we do what we call fish fluorescence in situ hybridization. A special X and Y probe dyes are applied to the embryo nucleus. We published it in 2016. At that time, it was the largest series in the literature, 351 cases. And 2016 years ago, it's still the largest series in the literature. بسم الله الرحمن الرحيم. مساء الخير على الجميع. أود أن أشكر الدكتور أحمد عبد الواحد وجمعية العلوم الطبية الإسلامية على هذه الدعوة الكريمة للحديث عن طرق تحديد جنس الجنين. وأنا سألت نصيحة أستاذنا الدكتور أحمد عبد الواحد أن يعطي المحاضرة بالإنجليزي ولا بالعربي. هو اقترح لأنه فيها ألفاظ طبية كتير إني أحكيها بالإنجليزي، فأنا طبعا نصائح أحكي المحاضرة بالإنجليزي، وحيكون في بعض الشغلات بالعربي على كيف بنحكي مع مرضانا لأنه بنحكي معهم بالعربي. بسم الله. People for a very long time wish to decide the sex of their babies. And this is as long as history. And we know from the writing of Aristotle, Galen, and Hippocrates that many methods have been written in their books. For example, Galen suggested sleeping on your right side if you want to have a boy, and on your left side if you want to have a girl, while Hippocrates suggesting tying off or removing your left testis to have a boy, although I wouldn't recommend that for you at home. And it wasn't in the early part of last century when Edmund Wilson and Nettie Stevens, independently working in Columbia and Pennsylvania, that they discovered and reported that the X and the Y bearing sperms are the deciders of the sex of the baby. And surprisingly, both of them reported that in 1905. And it took us another 85 years for Alan Handyside, who's now the professor of reproductive genetics in Kent University, when he was working with Bob Winston, some of you would recognize him on the picture on the right, reported in Nature in 1990 about PGD, pre-implantation genetic diagnosis, in order to determine the sex of the baby. Of course, we know that the normal sex ratio is 100 females to 101 males, and it is true that that's subhanallah, to compensate for the increased death rate of males during life. So later on, they equalize each other, subhanaka rabbi. Therefore, if someone uses any method and end up with a boy or a girl on that particular time, it doesn't necessarily that the method is working, because there is no third sex anyway. So you're either going to end up with a boy or a girl. And that's why when we hear things about the Jadwal al-Sini or al-Gharbale, they are useless. There is no scientific evidence whatsoever following the Chinese chart or the Erickson method that separates the X chromosome or X bearing chromosome from the Y bearing chromosomes makes any difference whatsoever in determining the sex in human beings. In giraffe, it makes a difference. In elephants, it makes a difference because their sperm are larger than our sperm proportionate to their size. But in the humans, the difference between the size of the XY bearing sperm and the Y bearing sperm is 2.8% in weight. And there is no method known to differentiate something as small as 2.8% in the weight of the sperm. So all these methods are useless. Even if someone swears that they've done it twice and they ended up with 2 boys, that was potluck, as we say. The only way that we can scientifically know what the sex of the baby is through IVF and pre-implantation genetic testing looking at the XY. As we say in Arabic, أطفال الانابيب وفحص الكروموسومات الجنسية قبل إرجاع الأجنة. Of course, there are so many types of PGT, pre-implantation genetic testing. We can do it to know the chromosomes, we call it PGTA. We can do it to know if there are any monogenic disorder such as thalassemia, for example, or sickle cell disease. We can do it SR, structural arrangement for the translocation. And that new trend that you'll be hearing more and more about it, but still experimental, is PGTP, polygenic disorders. Like what? Like hypertension, like diabetes, like autism. They are polygenic disorders. We don't have a single gene deciding them, but there is research now looking at the multiplicity of genes that may be contributing to them, and it won't tell you if the baby has or doesn't have that condition. It will tell you it has a higher chance or a lower chance. So this is an experimental, but many things we do now were experimental many years ago, and now they are standard practice. So watch this space. And what I hope to do in the next 10 minutes or so is to speak about the indication of the IVF PGT-XY, the methods, the results, and then just touch on the legal, ethical, and the religious considerations before we move on to our distinguished next speaker, so we hear what they're going to be said about. So why do we do it? We want to know the sex of the baby for two reasons: either medical sex selection or social sex selection. Medical sex selection is when we have a condition that predominantly happens in a particular sex. We call it X-linked disorders, and there are more than 200 conditions reported in the literature. One of them is Duchenne muscular dystrophy, X-linked recessive. It only happens in boys. So if someone is in an unfortunate family where they have that, then we can sex the baby and transfer girls. We know they are not going to be diseased with that condition. The other thing is social sex selection, and they call it family balancing. I think they moved to the term of family balancing because in the West, social sex selection was politically incorrect. It wasn't trendy. So they used something balancing. No one can object to balancing things, can they? And it's when coupled with children exclusively of a particular sex wish to balance their family by having child of the other sex. How do we do it? It's very simple. First, we do standard in vitro fertilization. We stimulate the ovaries to produce more than one egg. Then we do egg collection through transvaginal scan. Then we get the eggs there at the top. They ask the husband to produce a sample of sperm, and we inject the sperm directly into the egg using intracytoplasmic sperm injection. When I say we, it's not us, the clinician, it's our embryologists that do it. But you know, when things are successful, everyone claims to be part of it, and that's how it happens. And then when we reach day 3 and the embryo is about 6 to 8 cells, what the embryologists do is they make a small hole at the wall of the embryo. This video, by the way, is speeded up for the time, and then they take, and this is a cell. It does not affect the embryo. I say to my patient, it's like taking a hair from the head. More hair will grow instead of it. A lot of research has been done, and there are world registry with PGT showing that it has no ill effect on the embryo. No harm happens to the embryo with taking this. And the reason for that is because our embryologists will only do that with top grade embryos, because sometimes we have embryos that are not suitable for that, and we say to the couple, as I'll explain in a minute or so, we cannot do sexing for you. ما شاء الله إنه يكون في أجنة مناسبة. Okay, and then we do what we call FISH, fluorescence in situ hybridization. A special X and Y probe dyes are applied to the embryo nucleus, and another dye is applied to the embryo itself, or not to the embryo, to the cell. That's the cell we removed. So this cell doesn't go into the body and it doesn't form a baby. This is like I take a hair from your head or a blood sample from you and I examine it. You're away from the examination. It's just your sample is being examined. And if we get two red signals, it's a girl. And if we get a green and a red signal, it's a boy. We watch it under a fluorescence in situ hybridization, a fluorescence microscope. Okay, what about the results? I didn't practice social sex selection when I was working in the UK for 20 years because it wasn't standard practice there. But when I came back to Jordan 19 years ago, that was practiced here. So I started looking at it with fresh eyes. And everyone does it. But when you try to look at the published literature, there is virtually no published literature about it. Not because people are not doing it, but because they thought it was politically incorrect, not sexy enough for journals to look at it. So the biggest publication in the literature was only 42 cases from India. And all the other publications were opinion papers saying, I agree with it, I don't agree with it, it's a good thing, it's a bad thing. And we thought, well, how do we know it works? Could it work better than IVF? Because these are fertile couples as opposed to our infertile couples with IVF. Or is there something that we do that make it not work? Because, you know, not published, not done in medicine. Don't believe people saying if it hasn't been published. It is the evidence we rely on. So we decided, our group, to do a series and publish it. And indeed, we published it in 2016. We said what to expect from an in vitro fertilization, pre-implantation, genetic diagnosis, and gender selection program for family planning. At that time, it was the largest series in the literature, 351 cases, and 2016. And I checked with our friend ChatGPT 2 days ago. It's still the largest series in the literature. Now, I'm sure people have done more than that, but they haven't published it. So we really don't know. So I'm going to report on our published work, which remains the largest series in the literature about social sex selection. We had 351 cycles. All couples, by definition, had previous children, and all of them were of the opposite sex from the desired one. The wife age average was about 35, ranged from 20 to 43, and we did ICSI and PGT. Of all patients, 90% had embryos suitable for PGT, and 10% we didn't have embryos suitable for PGT, either because we didn't get eggs, or they did not fertilize, or the embryos, as I just explained, weren't suitable enough for the test. And of those PGT couples that reached that level, almost 95% had the desired sex. Either they had boys and girls, or the sex they want. So I say to my patient, there's a 5% chance of having girls, there's a 5% chance of having boys, and there is a 90% chance of having boys and girls, if you see what I mean. So the desired sex is present in 95% of cases, and in 5% of cases of those who reached PGT, we didn't find the desired sex. So we do not say, we will give you a boy and we will give you a girl. We will say, we will find out what you have, and we will find out what you have, and if you have what you desire, we will transfer it to you. It's as simple as that. And clinically, average number of embryo transfer 1.8, implantation rate, that's mean how many embryos you transfer, actually led to a sac with fetal heart, 26%, clinical pregnancy rate per embryo transfer 47%, and per cycle started 37%. In plain English, that means for every 100 couples that came and started working with us, 90 will have good enough embryos to test, 85 will have the desired gender, 40 will become pregnant, and 38 will reach the stage where there's a fetal heart. So out of every 100 couples, 38 will get pregnant. And we will explain verbally and in writing to the husband and wife, لا ضمان في وجود أجنة من جنس معين، لا ضمان في حدوث حمل بعد الإرجاع، لا ضمان في استمرار الحمل، وكله بأمر الله بنقول. احنا بس بندور وبنشوف شو بيطلع، احنا ما بنغير إشي، وبنحكي لهم إنه دقة تحديد جنس الجنين مش 100%، 99%. So why is that? Why do we only get 99%? There are three reasons, and it's interesting to look at them. There is the misdiagnosis rate. If you do FISH on XY on day 3 embryos, the misdiagnosed rate is about 1 to 3 in 1,000. Very low, but it does happen. And they consent to it in writing. And if they don't want to consent, we don't carry on with the treatment. Medicine is about giving your idea to people, explaining things to them, and they agree or they don't agree. That's why بقول لهم أنا بسموني استشاري، لأني استشار. بدكم تردوا على استشارتي تمام، ما بدكم على راسي برضه. We don't force anyone to have anything. The second thing is what we call superfecundation. We did IVF in the lab, but she happened to get pregnant from her husband during the same month. And maybe that baby at home was a different sex. So that's why we put a boy and we end up with a girl. I remember putting 2 boys in one of our patients, and she ended up with triplets. And we thought, gosh, maybe one of them has split. So he ended up with 1 boy and 1 monozygotic twin. But then we were surprised when they were two boys and a girl. So I asked them, we advised you not to have unprotected intercourse during the month. Did you follow our advice? And I saw the husband and wife looking at each other and smiling. And I knew what happened. So you say to your patients, during the month of the treatment, no unprotected intercourse. You can have protected intercourse by any method, coitus interruptus, condoms, husbands and wife are expert with these things. But if you have unprotected intercourse, that's fine, but you may end up with the wrong sex. So that's the second reason. And the third reason, it's rare, but it does happen. There are cases reported of XY female, 1 in 80,000, and there are cases reported of XX male, 1 in 20,000. So that's why we give a 99% probability rate of being accurate. And it's very important, I think, when we offer this service, that is a social rather than medical service, we are very open in writing and verbally. لا ضمان في وجود أجنة من جنس معين، لا ضمان في حدوث حمل، لا ضمان في استمرار الحمل، ولا ضمان في دقة 100%، ولكن هي 99% ونشرح المعيار. And all couples agree with that if they want to go ahead. Now at the end of my talk, I just want to speak, legally speaking. I told you that when I was in the United Kingdom, I didn't practice social sex selection because it was against the law. So social sex selection is prohibited in a number of countries in the world, like UK, Germany, Italy, Spain, Portugal, Switzerland, Canada. But in almost all other countries in the world, like all the Arab world and the United States of America and Asia, it is allowed by law. Or let's say not prohibited, because the law doesn't allow you, the law prohibits you from doing something. So you are prohibited from talking on your phone while you're driving. Okay, ممنوع تسوق وانت بتحكي تلفونك. بس القانون ما قال لك مسموح تشرب كاسة شاي وانت بتسوق، بس ما دام ما منعه فيعني سمحوا. اعتقد نفس القاعدة الفقهية الاصل في الاشياء الاباحة ما لم يرد بها دليل تحريم. الافكار الانسانية متشابهة في هذه الاشياء more or less. What about ethically speaking? I think if you discuss بيسموها الاخلاقيات. If you discuss the ethics of anything, any topic, you'll find some people are pro and some people are against. And people who are pro will find the reason, and people who are against will find the reason. These people who are opposed will say unnecessary medical intervention. Fair enough. Don't do it yourself then. And the people who support it will say patient's autonomy and reproductive rights. Fair enough. I don't see anything wrong or right. Those of us who study ethics and discuss ethics will find all sorts of different opinions. يعني موافق عليه أو غير موافق عليه. أنا ما بسميه الحق والباطل، لأنه الحق والباطل بين. ولكن إشي أنا موافق عليه وأنت مش موافق عليه، مثل ما بنحكي في العالم العربي، بس عمرنا ما بنسويها اختلاف الرأي لا يفسد للود قضية. إحنا عندنا في العالم العربي يفسد ويفسد ويفسد، بس خلينا نحاول، ليش لا؟ ندرس بركي بنوصل في الآخر. Okay, let me go back to this slide. When I came here, أول إشي بيسألونا يا مرضانا المسلمين، لأنه في مرضانا مسيحيين بيسألوا، لما بيسألونا بنقول لهم ما بنعرف، اسألوا رجال الدين عندكم. أنا لا أفتي في إشي ما بعرفه، أنا اللي بعرفه يا دوبك أجيبه صح، بدي أفتي في إشي ما بعرفوش. they ask us حلال ولا حرام. قلت لهم أنا مش رجل دين، ولكن خليني أشوف شو صاير. وصادف إنه الشيخ القرضاوي رحمة الله عليه كان جاي وبسوي مقابلة مع جريدة الغد في 3/9/2009، وسألوه نفس الرأي هذا، وقال إذا الرجل والمرأة متزوجين وعندهم عدد كبير من الأولاد ويرغبون في بنت، أو عدد كبير من البنات ويرغبون في ولد، فلا اعتراض على الموضوع، لا بأس به. فأنا حطينا هذا على الويب سايت تبعنا، بنقول لهم اسألوا أهل الذكر إن كنتم لا تعلمون، نحن لا نعلم ولكن هذا أحد أهل الذكر. وأعتقد اتفقت أو اختلفت مع الشيخ القرضاوي الله يرحمه. ثاني شيء، دار الإفتاء المصرية نزلت في حكم على تحديد نوع جنس الجنين وضوابطه، أنه يجوز للإنسان شرعا أن يأخذ بالأسباب والوسائل، ومن جملة الأسباب والوسائل ما ينصح به الأطباء المختصون، ومنها التعامل المجهري مع الكروموسومات والمادة الوراثية. وأخذوا الدليل أنه الأنبياء طلبوا أولاد من الله سبحانه وتعالى، وما جاز سؤاله وطلبه جاز بذل السبب لتحصيله. وقالوا برضو الأخذ بالأسباب لا يتنافى مع مشيئة الله سبحانه وتعالى. الأسباب التي قضى الله أن تكون سببا لمسبباتها لا تخرج عن تدبيره ومشيئته، الله خلقكم وما تعملون. هاي كان رأيه. في ناس في الأزهر أفتوا فيها. الله يرحمه الشيخ دكتور محمد رأفت عثمان، كان عميد كلية حقوق وعميد كلية شريعة في القاهرة، وأفتى بجوازها مستندا في فتوى على أنه لا يوجد نص قرآني يحرم ذلك، أنه ذلك من باب المستحدثات في الفقه. ولكن في شيوخ أزهريين ما وافقوا معه واختلفوا. وكان برضو هذا الفتوى تبع دار الإفتاء العام في الأردن، لما قالوا لما تكون عملية جنس الجنين، تحديد جنس الجنين للقادر على الإنجاب فلا تجوز، ولكن إذا كان غير قادر على الإنجاب الكابل فلا بأس به. ولكن إذا بدنا نستخدم أساليب أخرى لا تترتب عليها محاذير شرعية فبرضه لا بأس بها. فأي واز انترستد إني أعرف شو هم المحاذير الشرعية اللي قالوا اللي هي بتخليها مش مظبوطة. فرجعنا شفنا شو هي المحاذير الشرعية اللي دار الإفتاء عنا قالت عليها. قالت لك أول إشي كشف العورة المغلظة للمرأة وفي أكثر الأعضاء حرجا ولأمر لا تتوقف عليه حياة المرأة، وجهة نظر برضه. الإشي الثاني قالوا الخشية من اختلاط الأنساب. أنا استغربت كيف اختلاط الأنساب، ما احنا في الاي في اف بنسوي نفس الإشي، الاي في اف العادي يعني. وقوع ممكن اختلاط الأنساب بسبب الخطأ أو عمدا بسبب فساد الذمم، واللي اعتمدوا عليه انه فسدت الذمم لدرجة ان كل الدول تشكو من فساد الذمم وتشكل هيئات خاصة لمحاربتها. فهيئة محاربة الفساد كنا انه شكلناها، هذا دليل انه ممكن يصير هيك عنا. هذا المكتوب في دار الإفتاء من عنا. وقالوا برضو انه ممكن الزوج يطلب من الدكتور انه يبدل الماء تبعه، او ممكن الزوجة تطلب من الدكتور انه تبدل البويضات تبعها في تحديد جنس الجنين، مش في اطفال الانابيب العادية يعني بيحكوا. وقالوا برضو ممكن الطبيب رغبة منه في اظهار مقدراته على علاج العقم مما يجلب عليه الشهرة والثروة. هذول ما بيعرفوا انه الدكاترة لا فيها شهرة ولا فيها ثروة، بس الحمد لله ممكن يخبص في الموضوع. ولكن اختلاف الرأي لا يفسد للود قضية، وكما قال السلف الصالح رحمة الأمة في اختلاف الأئمة. That's why we think different opinions are valuable in this thing. Thank you for your attention.